So, in this system, we're going to talk mostly about nociceptive pain. So, at least for this part of the series, we will speak about pain that does have a nociceptive physiological tissue-based cause. Now, whether or not we can actually work that out, exactly what it is, we're going to proceed with that fundamental assumption. This doesn't take into account sensitization at a peripheral or central level. We will deal with that much more in the upper stages of the courses, but at this point, we've got to assume that we've got a physiological basis for the signs and symptoms that we're seeing. Obviously, a fundamental part of that is the pain chart. So you'll be seeing that through certainly the rest of this presentation. So I'll start with radicular pain. Radicular pain is a very specific type of pain. This is as described by Bogduck straight out of his article. You'll note here the features, excuse me, very narrow area of pain, either in the anterior thigh or the posterior thigh. If it's in the posterior thigh, it tends to go all the way from the butt all the way down to the leg. If it's in the anterior thigh, it tends to only go to about the knee. We'll assess these with straight leg raise. Obviously, straight leg raise will assess the posterior. Femoral nerve test, prone knee bend will assess the anterior. This is a very particular type of pain that patients will complain of as sharp, shooting, burning, electric, excruciating, lancinating. Not a word you hear in America very much, but it does indicate the severity of the pain. This is severe pain. It tends to be intermittent. It doesn't always tend to be continuous or constant. Constant radicular pain usually is enough to keep them away from physical therapy. The seriously important thing here is that only if the nerve root has been previously inflamed does mechanical pressure invoke radicular pain. Now, the pain can come from traction, compression, or just the inflammatory response itself. So there's three basic mechanisms of getting it. But the key is that you only see this particular pattern of pain in a previously inflamed or damaged nerve root. And Kobayashi gives us the seminal work on exactly how the radicular pain develops, but it's essentially an ischemic response to a lack of blood flow in the small arteries that supply the radicular nerve root. So radicular pain, neuropathic pain, very clear to make sure that we understand that it is only this type of pain that is true radicular pain. And it can be present with other types of pain, or it may be independent on its own, but we have to see these things on the pain map, and we have to have previous damage to the nerve root. If there's not previous damage to the nerve root, then the only thing we're really looking at is a loss of neurological function, which is what we get when we compress neurological tissue. So you'll lose sensory function and you'll lose motor function in relatively predictable patterns based on the tissue that's been compromised. So radicular pain is way overdiagnosed in relation to its actual presentation. So very, very important to understand the parameters of what we're looking at here. Local nociceptive pain is pain that is evoked as a result of discharge of free nerve endings and nociceptors in the local target tissue. In this case, we're looking at the lumbar spines. This would be a local facet pain, or a local SI joint problem, or an L5S1 segmental dysfunction, or in this case a TL junction. The interesting thing about nociceptive pain, it tends to be local, obviously. Oh, that's not very good spelling, sorry about that. It tends to be local, it tends to be acute, it tends to be a small area, and it tends to be superficial. People will use words like sharp and close to the touch, and it's typically mechanical when this happens. It doesn't happen over a broad area. The interesting thing is that the further distal you see nociceptive pain, the more likely it is that the source and the localization of the pain can be correlated with the specific anatomical structure. So for instance, if you have pain directly over the shaft of the second metatarsal, it's very likely that you can palpate that, and it's very likely that that is actually the source of the patient's symptoms. Same thing with a lateral ankle sprain, or same thing with a Boxer's fracture in the metacarpals of the hand. The further proximal you go, the less reliable it becomes. Local nociceptive pain in the area of the hip is almost useless as a diagnostic sign from palpation, because this is obviously one of the most common areas of pain in the human body. for people to come in and complain of lateral hip pain, posterior thigh pain, posterior buttock pain is a very common area for people to have pain. So you can't use it as a reliable indicator of diagnostics. Referred somatic pain is quite simple to understand. Referred somatic pain is simply pain that is felt in a source, pain that is felt in an area distant to its actual origin. So these are some pretty classic maps from Mooney and Robertson. This was actually done back in 1976, and you can see you've got normals on this side, abnormals on this side, and what they essentially did was just inject the facet joints here with hypertonic saline, and they were able to determine from that where exactly the pain maps were. So you can see here that the concept of peripheralization is the worse the pain is and the worse the stimulus is, the further distal you'll actually get the referral of these signs and symptoms. So, and again, look at this composite here. So this referred somatic pain. Referred somatic pain will be patients will complain of dull, aching, gnawing, expanding pressure. They'll say it's vague. They'll say it's very difficult to outline the exact margins of where it is. It tends to be mechanical, so it tends to be acute, tends to be episodic, tends to be intermittent. And this really is what we're all about. This is what we see. This will usually happen in concert with local nociceptive pain. It usually begins as nociceptive pain and then will spread from the origins out to the peripheral boundaries as it gets worse. So that's why we like to see centralization. We like to see referred pain coming back into the central system rather than staying in the peripheral area. But this is the heart of what we do. Acute, episodic, intermittent, and we want pain that can be reproduced, aggravated, and relieved. And that's the key of referred pain of somatic source, is that we can reproduce it with movements, positions, activities, and postures, which differentiates it very much from the next one we're going to talk about, which is referred visceral pain. Referred visceral pain, looking at these maps here. Now it's very interesting here, if you look in the neck areas, they very much mimic musculoskeletal pain areas. Not so much in some ways it does, but you've got a much better anterior representation. But interestingly enough, look at the kidney range here. Tends to be flank pain, which tends to be a little higher and a little more lateral than what you'd see in low back pain. Don't tend to get any central buttock pain here, but the kidney pain can go all the way down into the lateral thighs and the hips. We've always got to be on the lookout for that. Anterior pain is never a good thing. Colon, appendix, kidney, pancreas, the pancreas and stomach up here, the liver and the gallbladder. So we can see anterior pain is never a good thing from a musculoskeletal point of view. Anytime we see anterior pain, we should be immediately suspicious of visceral involvement. The biggest thing with visceral involvement is the behavior. You will still get dull, aching, and gnawing, and sometimes an expanding ache. It tends to be more continuous, it tends to be more constant, and it tends to be related to the behavior of the organ, in that it is not mechanically reproducible, so it doesn't get better or worse with movements, positions, activities, and postures. And that is the key thing to interpreting some of the different pain definitions, is that it will be more likely to be constant, be continuous, related to the function of the organ, slowly developing, slowly progressive, gradually progressive, and there won't be any mechanical component to it. This is a very key part of the screening process that we'll be going through as we move through the system here. So it's just another way of, again, looking at the behavior of the somatic pain. Behavior of somatic pains tends to be acute, episodic, intermittent, moderate intensity, moderate referral, reproduced, aggravated, and relieved by movements, positions, activities, and postures. So this is a really key thing when we start talking about screening, is because we can screen by looking for symptoms of visceral disease, or we can screen by looking for the absence of this. So in terms of who shouldn't we be seeing in the clinic, what I like to look at is who should we be seeing. We see people with somatic, local nociceptive, and somatic referred pain. People who have acute, episodic, intermittent symptoms. People who have symptoms of moderate intensity, moderate referral, and that can be reproduced, aggravated, and relieved by movements, positions, activities, and postures. If it doesn't fit that pattern, then there should be a very real question as to whether or not we should be seeing the patient in the physical therapy clinic. Restatement of the initial. Non-somatic pain is a red flag, or at least a yellow flag. So if the pain is not acute, episodic, intermittent, moderate intensity, moderate referral, relieved, aggravated, reproduced by movements, positions, activities, and postures, then we should at least ask questions or do a very thorough clinical exam before we agree that the patient can be in our clinic. Constant pain is almost always a red flag. And true constant pain is pain that is always there, never goes away, even for a second. And a lot of times I'll ask patients about their pain levels and say, well, how much pain do you have? Is it always there? Yes. Important thing then is to follow up to say, so that means that the pain is there all the time, it never goes away, it's always present. And typically the deeper you dig, the more you're able to find that there's actually continuous types of pain. And continuous, this means they're for long periods of time, but not there all the time. So typically people don't have constant pain, but they tend to have some breakup of the pain, which makes it more mechanical. Right, just a little bit more here on radiculopathy. Very important to understand is radiculopathy at the heart simply means pathology of the nerve root. It is not a pain state. Radiculopathy will lose motor function and you'll lose sensory function related to the function and the context of that nerve. When you block the sensory nerves, numbness. When you block the motor nerves, motor weakness. Radiculopathy is not defined by pain, but please don't take that to mean that radiculopathy is not associated with pain. You can certainly have a painless radiculopathy, which often happens in the neck, particularly when you get sensory dysfunction. But radiculopathy can be associated with either or, local nociceptive pain, referred somatic pain, or even radicular pain. But the key is to understand understanding that radiculopathy can exist as an independent entity, and radiculopathy is not defined by a pain state. It is a completely separate entity. There are a couple of ways we measure pain. We've got the visual analog pain scale, which we're all familiar with. We also have the numeric pain rating scale, both used pretty intensively in research. Just depends on exactly where we're going to be doing the research. How do we document pain? We document it by the location of the pain, the quality of the pain, the severity of the pain, the timing, and obviously the aggravating and relieving factors. And this might be a basic subjective example that you can read there. That's a pretty good description of the pain. And then we can see the different elements here as we cycle through it. So you can see the location of the pain is the right knee localized there. You can also see the quality of the pain. And we can see the severity of the pain. And we can see the timing of the pain. And we can see the aggravating and relieving factors. So hopefully that was just designed to be a very basic introduction. I very much encourage you to read the Bogduck article, and I'm happy to get that to you. If you would like to read it, please just email me. You can email me at brettwindsor@gmail.com, brettwindsor@gmail.com. And I wanted to finish just by introducing a reference here. This book is about 20 years old now, but it's definitely changed the way I look at my practice of pain, and discusses Paul Brand, who was an orthopedic surgeon who spent half his life in India and half his life in America, dealing with initially leprosy patients and diabetic patients. And the interesting thing with both of them is that he was dealing with the absence of pain, which is in itself is a pretty significant problem. So you can pick this reference up on Amazon.com. It's usually only $6 to $10. Although I don't know, maybe I've told so many people about it now that I've driven up the demand. But if you are interested in a little bit different take on the pain, this is very story oriented. It's not technical, which was great for me because you're not into the Mills-Acuin and Wall deep technical articles. But anyway, I hope this little presentation has been interesting and helpful. Please follow through with the quiz on the other side of this, and we'll be talking about pain more in the course. Thank you very much.